Okay, today we will be seeing about smear layer in endodontics. The term smear layer is used most often to describe the grinding debris left on dentin by cavity preparation. However, the term applies to any debris produced iatrogenically by the cutting not only of dentin but also of enamel, cementum, and even the dentin of the root canal. The complete cleaning of the root canal system has always been a problem in endodontics. Although successful endodontics is based on the fundamentals of diagnosis, instrumentation, and obturation, it is generally recognized that debridement of the root canal is the most important aspect of successful endodontic treatment. Smear layer differ from dusty pattern of the superficial debris in that it is the layer of muddy material composed of an amorphous layer of organic and inorganic debris and sometimes the bacteria also, and it is assumed that the debris and bacteria left inside the canal can affect the prognosis of the root canal treatment. Coming to the concepts of smear layer, it is difficult to say that when or by whom the concept of the smear layer was first introduced. The earliest studies on the effects of various instruments on dental tissues were those reported by Lamy Dricot in 1952. Their attempts were limited principally to light microscope and it has consistently failed to identify the smear layer. Boyd et al. In the year 1963 was the first to describe and demonstrate the presence of smear layer. They concluded that an organic layer containing apatite particles was deposited or smeared on the enamel surface through functional heat generated during cutting. Provenza and Sardana in the year 1996 evaluated means of removing the debris from enamel and dentin after the use of steel burrs, diamond stones, and hand cutting instruments. They reported variations in the degree to which the debris was removed. Detergents were relatively ineffective. EDTA, ethylene diamine tetraacetic acid, left behind the film. Hydrochloric acid was considered too destructive in its action, and hydrogen peroxide appeared to be most effective. Researchers became aware of the endodontic smear layer by about 1975. It was first reported by Baker. Tidmarsh in the year 1978 treated instrumented teeth with 50% citric acid and found the dentin clear of smear layer and the dentinal tubules wide open. Goldman in the year 1979 tested various solutions individually and in combination and concluded that chelating agent EDTA and sodium hypochlorite was the best to remove the debris when used as final flush. Evans injected thermoplasticized gutta percha into the canals after the smear layer removal and concluded that the presence or absence of the smear layer had no significant effect on the apical seal. Coming to the definition, according to Schwartz, any debris calcific in nature produced by reduction or instrumentation of the dentin, enamel, or cementum, or as a contaminant that precludes interaction with the underlying pure tooth structure is the smear layer. According to Cohen, smear layer is an amorphous, relatively smooth layer of microcrystalline debris whose featureless surface cannot be seen with naked eye. The American Association of Endodontists defined smear layer as a surface film of debris retained on the dentin or other tooth surfaces like enamel, cementum after instrumentation with either rotary instruments or endodontic files. According to DCNA, in the year 1990, when the tooth structure is cut, instead of being uniformly sheared, the mineralized matrix shatters. Existing on the strategic interface of restorative materials and the dentin matrix, most of the debris is scattered over the enamel and dentin surface. This is known as smear layer. In endodontics, the smear layer results directly from the instrumentation used to prepare the canal wall and is found only where the wall is instrumented and not in uninstrumented areas. Because it is a very thin layer and is soluble in acid, it is not very apparent. It cannot be seen in demineralized teeth as it dissolves in the process of demineralization. It is only visible under scanning electronic microscope or other advanced tele-electron microscopes. The smear layer has an amorphous, irregular, and granular appearance when viewed under the scanning electron microscope. The appearance may be formed by translocating and burnishing the superficial components of the dentin walls during endodontic instrumentation. The smear layer consists of two separate layers, a superficial layer and a loosely attached layer to the dentin. The smear layer is made up of tooth particles ranging from less than 0.5 micrometer to 15 micrometer. The particles are composed of globular subunits approximately 0.05 to 0.1 micrometer in diameter, which originated from mineralized fibers. The thickness of this layer is 1 to 5 micrometer. The depth entering the tubules may be from a few micrometer up to 40 micrometer. Several factors may cause the depth of the smear layer to vary from tooth to tooth. Dry or wet cutting of the dentin, the size and shape of the cavity or root canal, the type and sharpness of the instrument used, the amount and chemical makeup of the irrigation solution. If there is a difference in the rate of flow of the fluid across the dentin before and after removal of the smear layer, the magnitude of rate change is an indication of the thickness or density of the smear layer. Dentin is composed of two different layers, superficial dentin which is near the enamel and deep dentin which is near the pulp. The smear layer on deep dentin contains more organic material than superficial dentin. This is because of greater number of proteoglycans lining the tubules or the greater number of odontoblastic processes near the pulp. The movement of the fluid across the dentin meets a resistance directly proportional to the quantity and quality of the smear layer present. In vital teeth, the smear layer restricts the dentinal fluid from flushing the dentin surface. It also hinders the chemical process that produces marginal seal. The presence of smear layer, however, does not appear to restrict the adaptation of the condensed amalgam to the cavity surface. According to some investigators, after a canal is instrumented, the smear layer produced can harbor bacteria and bacterial products that can be a reservoir of potential irritants. The smear layer is a separate structure from the underlying dentin and may crack open and pull away from the underlying dentinal tubules. A situation like this could be harmful to the foundation of gutta percha obturated over the smear layer. Hence, they thought it best to remove the smear layer, though controversy still remains. Factors affecting the formation of smear layer in endodontics. Type of instruments. Increased centrifugal forces resulting from the movement and the proximity of the instrument to the dentin wall forms a thicker and more resistant smear layer, and thus the amount produced during automatic preparation, as with Gates Grit Grill or post drills, will be greater in volume than that produced by hand filing. Coming to the dentin cut, which is wet or dry, filing a canal without irrigation or cutting without a water spray will produce a thick layer of dentinal debris and smear layer. Proximity of the instrument of dentinal walls. More closely the instrument to the dentinal walls, more is the centrifugal forces producing thicker smear layer. Size and shape of the root canals. The authors explained that on account of the reduced dimension of the root canal, air bubbles frequently remain trapped and prevent total filling with the irrigant. Mechanical stirring with the lentulospiral removes the air bubbles, favors improved contact of EDTA with the canal walls, and takes the solution to areas that are not reached by the irrigating needle. Coming to the components of the smear layer, though the exact proportion of the composition is not certain, it is composed of both organic component and inorganic component. Inorganic component is made up of tooth structure and some non-specific inorganic components. Organic component consists of heated coagulated proteins, which is usually the gelatin formed by the deterioration of collagen heated by cutting temperature, necrotic or viable pulp tissue, odontoblastic processes, saliva, blood cells, and microorganisms. Advantages of smear layer in endodontics are it is reduction of dentin permeability to toxins and oral fluids, reduction of the diffusion usually inwards by convection and outwards by hydrostatic pressure of fluids and prevents wetness of the cut dentin surface. And also bacterial penetration of dental tubules is prevented. Disadvantages of smear layer are It may harbor bacteria either from original caries lesion or from saliva, which may multiply taking nourishment from the smear layer or dentinal fluid. Smear layer is permeable to bacterial toxins. Smear layer itself is infected with the presence of bacteria. The smear layer may prevent the adhesion of composite resin system, bonding agent, and zinc polycarboxylate cements. It blocks the it blocks the antimicrobial effects of intracanal disinfectants and increases the disinfecting tissue. And the presence of smear layer would necessitate use of higher concentration or amount of antibacterial agents. It acts as and it acts as intermediate physical barrier that interferes with the adhesive penetration of the sealers, that is in the obturating materials with the dentinal walls. Coming to the physical barriers for bacteria and disinfectants, when the pathological changes occur in the dentinal pulp, the root canal system can harbor several species of bacteria, their toxins, and their byproducts. These bacteria are predominantly gram-negative anaerobes. The morphology of the root canals is very complex, therefore, the mechanically prepared canals contain areas not accessible by endodontic instruments, and bacteria will be found more in number in these areas. The available evidence shows that bacteria and its byproducts present in infected root canals may invade the dentinal tubules. Investigators have reported the presence of bacteria in the dentinal tubules of infected teeth at approximately half the distance between the root canal walls and the cemento-dentinal junction. The bacterial penetration into the dentinal tubules is seen up to 150 micrometer in the apical two-thirds of the root. Thus, even after chemomechanical instrumentation of the root canal, some bacteria still remain in the canal and dentinal tubules. For this reason, chemomechanical cleansing is often supported by the use of disinfectants. Drake et al. Showed that the removal of smear layer opened the dentinal tubules, allowing bacteria to colonize in the tubules to a much higher degree, that is tenfold compared with the roots with an intact smear layer. Removal of smear layer facilitates passive penetration of bacteria. According to some authors, the presence of smear layer may block the antibacterial effects, antimicrobial effects of intracanal disinfectants into the tubules. Various medicaments have been proposed for disinfection of root canals. They are traditional phenolic or fixative agents like camphorated monochlorophenol, formocresol, non-phenolic compounds like iodide and calcium hydroxide. Researchers found that in the absence of smear layer, liquid camphorated monochlorophenol disinfected the dental tubules rapidly and completely, but calcium hydroxide failed to eliminate Enterococcus faecalis even after 7 days of incubation, and hence concluded that smear layer did delay but not abolish the action of the disinfectants. However, following removal of smear layer, bacteria in the dental tubules can be destroyed. Smear layer and micro leakage. An important consideration in endodontics is the ultimate seal of root canals in order to prevent possible micro leakage, which may be the cause of future failure of the root filling. Prepared dentin surfaces should be very clean to increase the sealing efficiency of obturation. Smear layer on the root canal walls acts as intermediate physical barrier and may interfere with adhesion and penetration of sealers into dentinal tubules. Investigators observed that plastic filling materials and sealers penetrated into dental tubules after the removal of smear layer, and its presence obstructed their penetration. The penetration in smear-free groups ranged from 40 to 60 micrometer. They concluded that tubular penetration may increase the interface between the filling and the dentinal structures and thus may prevent leakage. Apical leakage. According to Evan et al., the use of injected thermoplasticide gutta percha should be accompanied by the use of sealer regardless of whether or not the smear layer has been removed. But Kennedy stated that an absence of the smear layer causes less apical leakage than gutta percha filled canal with the smear layer intact. Sealers. Endodontic sealers act as a glue to ensure good adaptation of gutta percha to the canal walls. If the smear layer is not removed, then the gutta percha is not firmly attached to the dentin and the smear layer may laminate off the canal wall and create a false seal and voids in the fill and an environment for micro leakage. The type of sealer used for different implications once the smear layer has been removed. For example, Grossman sealer, which is a powder liquid combination, contains small particles in the powder that enter the dentinal tubules and create a secure interface between sealer and canal wall. After the removal of smear layer, calcium hydroxide based sealers promote the opposition of the cementum at the canal apex and seal it off against micro leakage by the formation of osteoid or dentoid type material. Circulation of blood is needed for the calcium ion to promote new tissue, thus the calcium hydroxide sealers are effective for sealing only at the root apex. If more cementum is going to form to create a better apical seal, dentin chips at the apex of the root canal, which acts as a nidus for the formation of hard tissue. Bacterial contamination by the presence of smear layer can prevent this. Urethane dimethacrylate based root canal sealers have been introduced. Their aim is to provide a better bond to allow less micro leakage and to increase the fracture resistance of root filled teeth through the creation of monoblocks when a core material such as Resilon replaces gutta percha. Some studies indicate that smear layer removal leads to higher tubule penetration, increased sealer to dentin bond strength, and enhanced fluid tight seal. Coming to post cementation, removal of smear layer increases the cementation bond and the tensile strength of the cementing medium for post cementation. Glass ionomer cements are effective in post cementation after smear layer removal because the glass ionomer has better union to structure. When the smear layer was removed by flushing with EDTA and sodium hypochlorite rinse, the unfilled bis-GMA resin, that is the cementing media, flowed into the exposed dentinal tubules and into serrations on the post, improving retention vastly. And with the removal of smear layer and an unfilled resin bonding agent, shorter posts can be suggested. Coming to the functional implications, in dental materials, the presence of smear layer masks the underlying dentin matrix and may interfere with the bonding of the adhesive dental cements such as polycarboxylates and glass ionomer that reacts chemically with the dentin matrix. The cements that react chemically to smear layer rather than the matrix of sound intertubular dentin produce a weaker bond as the smear layer can be torn away from the underlying matrix, and when these cements are tested for tensile strength, the failure can be either adhesive, that is between the cement and the smear layer, or cohesive between the constituents of smear layer. To increase the tensile strength of a cement dentin interface, there are several approaches. The number one approach is remove the smear layer by etching with acids. This procedure does not injure the pulp if dilute acids are used for shorter periods of time. Example, etching dentin with 6% citric acid for 60 seconds removes all the smear layer, as does 15 seconds of etching with 37% phosphoric acid. The advantages are that the smear layer is entirely removed, the tubules are open and available for increased retention, and surface collagen is exposed for covalent linkage with new experimental primers for cavities. The disadvantage is that there is physical barrier for bacterial penetration and the permeability of dentin increases. Coming to the methods to remove the smear layer, chemical removal. The quantity of smear layer removed by a material is related to its pH and the time of exposure. A number of chemicals have been investigated as irrigants to remove the smear layer. According to Kaufman and Greenberg, a working solution is the one which is used to irrigate the canal. Chlorhexidine, while popular as an irrigant and having a long-lasting antibacterial effect through adherence to dentin, does not dissolve organic material or remove the smear layer. Sodium hypochlorite. The ability of sodium hypochlorite to dissolve organic tissue is well known and increases with rising temperature. However, its capacity to remove smear layer from the instrumented root canal walls has been found to be lacking. The conclusion reached by many authors is that the use of sodium hypochlorite during or after instrumentation produces superficially clean canal walls with smear layer present. Chelating agents. Smear layer components include very small particles with a large surface, which makes them soluble in acids. The most common chelating solutions are based on ethylene diamine tetraacetic acid, which reacts with calcium ions in dentin and forms soluble calcium chelates. It has been reported that EDTA decalcified dentin to a depth of 20 to 30 micrometer in 5 seconds. Different formulations of EDTA have been used as root canal irrigants. In a combination, urea peroxide is added to encourage debris to float out of the root canal. Many studies have shown that paste type chelating agents, while having a lubricating effect, do not remove the smear layer effectively when compared to liquid chelating agent. A quaternary ammonium bromide, which is cetrimide, has been added to EDTA solutions to reduce the surface tension and increase the permeability of the solution. McComb and Smith reported that when this combination was used during instrumentation, there was no smear layer remaining except in the apical part of the canal. This study also showed that EDTA cetrimide combination was the most efficient irrigating solution for the smear layer. Bis dequalinium acetate, a dequalinium compound and an oxime derivative has been shown to improve the smear layer throughout the canal, even in the apical third. Salvixol, which is invented in Germany, is a commercial brand of 0.5 percentage bis dequalinium acetate and possesses the combined actions of chelation and organic debridement. Kaufman et al. In the year 1978 reported that salvisol had better cleaning properties than other chelating agents. When comparing solvisol with 5.25% sodium hypochlorite, both were found comparable in their ability to remove organic debris, but only salvisol opened dentinal tubules. Tetracyclines are antibiotics effective against a wide range of microorganisms. Tetracyclines have unique properties in addition to their antimicrobial aspect. They have low pH in concentrated solution, and because of this, they can act as calcium chelator and can cause enamel and root surface demineralization. The surface demineralization of dentin is comparable with that of citric acid. Barcoder et al. Reported that doxycycline hydrochloride was effective in removing the smear layer from the surface of instrumented canals and root and cavity preparation. Hasney in the year 2001 suggested that 1% tetracycline hydrochloride or 50% citric acid can be used to remove the smear layer from surface of the root canals. In an effort to produce an irrigant capable of both removing the smear layer and disinfecting the root canal system, Torabinajit et al. In the year 2003 developed a new irrigating solution containing a mixture of tetracycline isomer, an acid, and a detergent, which is called famously as MTAD. Their work concluded MTAD to be an effective solution for removal of the smear layer. It does not significantly change the structure of the dentinal tubules when the canals are irrigated with sodium hypochlorite and followed with the final rinse of MTAD. Components of MTAD are among the acids EDTA, acetic acid, citric acid, tannic acid, polyacrylic acid. By dequalinium acetate, this helps to remove the smear layer. And in the antibiotics, tetracycline, which has bacteriostatic and prevents the production of endotoxins is seen. Among the detergent's main function is to decrease the surface tension and increase the permeability of the dental tubules. Coming to the organic acids, the effectiveness of citric acid as a root canal irrigant has been demonstrated by Lowell in the year 1975 and Tidmarsh in the year 1978 and confirmed to be more effective than sodium hypochlorite alone in removing the smear layer. Citric acid removed smear layer better than polyacrylic acid, lactic acid, and phosphoric acid, but not EDTA. Citric acid, in addition to removing the smear layer, is a powerful antimicrobial agent, but its antimicrobial action is not as great. As that of 5.25% sodium hypochlorite, which acts as a broad spectrum antibiotic effectively against bacteria, bacteriophages, spores, yeasts, and viruses. Combining the two, sodium hypochlorite followed by 6% citric acid would give an ideal endodontic irrigant. Wayman et al. In the year 1979 showed that canal walls treated with 10%, 25%, and 50% citric acid solution were generally free of smeared appearance, but they had the best results in removing smear layer with sequential use of 10% citric acid solution, 2.5% sodium hypochlorite solution, then again followed by 10% solution of citric acid. However, Yamada et al. In the year 1983 observed that 25% citric acid sodium hypochlorite group was not as effective as 17% ethylene diamine tetraacetic acid sodium hypochlorite combination. Berry et al. Reported polyacrylic acid at 40% to be very effective for the removal of smear layer. They have been used to demineralize dentin surfaces, uncover and widen the orifices of the dental tubules, and expose the dentin collagen matrix. Sodium hypochlorite and EDTA. When irrigating a root canal, the purpose is of twofold. Number one is to remove the organic component, the debris originating from the pulp tissue and microorganisms. And number two, the mostly inorganic component, the smear layer. As there is no single solution which has the ability to dissolve organic tissues and to demineralize the smear layer, the sequential use of inorganic solvents along with the irrigants has been recommended. Numerous authors have agreed that the removal of smear layer as well as soft tissue debris can be achieved by alternate use of EDTA and sodium hypochlorite. Goldman et al. In the year 1982 examined the effect of various combinations of EDTA and sodium hypochlorite, and the most effective final rinse was 10 ml of 17% EDTA followed by 10 ml of 5.25% of sodium hypochlorite, a finding confirmed by Yamada et al. Coming to the ultrasonic smear layer removal, following the introduction of dental ultrasonic devices in the year 1950s, ultrasound was investigated in endodontics. Sodium hypochlorite activated by an ultrasonic delivery system was used for the preparation and irrigation of canals, and smear-free canal surfaces were observed using this method. Researchers who found the cleaning effects of ultrasonics beneficial used the technique only for the final irrigation of root canal after the completion of hand instrumentation. This has given the term passive ultrasonic irrigation. Ahmad et al. In the year 1987 claimed that direct physical contact of the file with canal walls throughout instrumentation reduced acoustic streaming. Acoustic streaming is maximized when the tips of the smaller instruments vibrate freely in the solution. Baumgartner and Quinnen in the year 1992 observed that ultrasonically energized sodium hypochlorite, even at full strength, did not remove the smear layer from the root canal walls. Gurisoli et al. In the year 2002 evaluated the use of ultrasonics to remove the smear layer and found it necessary to use 15% EDTA with either distilled water or 1% sodium hypochlorite to achieve the desired result. Coming to the laser removal, lasers can be used to vaporize tissues in the main canal, remove the smear layer, and eliminate residual tissue in the apical portion of the root canals. The effectiveness of lasers depends on many factors, including the power level, the duration of the exposure of the laser, the absorption of the laser light in the tissues, the geometry of the root canal, and the tip to target distance. Takeda et al. Using the erbium yttrium aluminum garnet laser demonstrated optimal removal of smear layer without the melting, charring, and recrystallization effect. The main difficulty with laser removal of the smear layer is access to the smaller canal spaces with relatively large probes that are available. Coming to the conclusion, the problem of smear layer is yet a controversy. To keep it or remove it is still a problem and controversy. However, if the smear layer is to be removed, the method of choice seems to be the alternate use of EDTA and sodium hypochlorite solutions. It is up to the dentist's judgment, knowledge, and understanding to treat the smear layer or not. Clinical investigations are needed to determine the role of smear layer in the outcome of root canal therapy. These are my references. Thank you.